Thank you, Raju sir. So, good evening, everyone, and thank you, GART, for providing this opportunity to share our experience and knowledge. Today, we will discuss cross-sectional anatomy for radiotherapy technologies, one of the most important skill required in radiation oncology. Our goal is to identify, recognize target volumes, organ trace, and anatomical landmark that will be useful during the image guidance. The knowledge gained today will be help to improve the patient care, setup accuracies, and image matching during IGRT procedures. So, objective of this session is identify the important bony and soft tissue landmarks, image verification before treatment, which will help in image verification, and understanding the significance of the anatomy knowledge during the CT simulation. Communication with the oncologist will be helpful if we know the proper anatomy. It will also helpful in decision making before initiating a treatment, and in a patient communication also regarding the patient treatment protocol, that is bladder protocol or empty stomach protocol. We have to communicate with the patient in certain cases. So we will explain and explore one by one. So CT image orientation is like we are standing at the feet of the patient. So we are viewing the image as we are standing at the patient's feet, looking towards the patient head. So the patient's right side is on the left side of the image. Here we can see this is left side, patient's left side, and viewer's right side means our right side. And patient left side appears on the right side. Patient right side is viewer's left side. So top of the image is always anterior, and back of the image is always posterior. And we are just moving from superior to the inferior while reviewing the anatomy CT slice images. So understanding this notations will be helpful, and it will avoid confusion also. So this is the first slice of the brain CT. Brain is one of the complex structure in a radiotherapy. So understanding the brain anatomy will help in whole brain radiotherapy, stereostatic radiotherapy, and stereostatic radiosurgery also, where high dose of is delivered with the nearby, avoiding the dose to the nearby critical structures. So today we will identify the cerebral lobes, ventricle, cerebellum, brainstem, skull-base structures, and important other intracranial organs. This is one of the most superior axial CT sections of the brain, represent the partial bone, parietal bone, which forms the cranial wall. So this is the parietal bone. All white structure is our parietal bone, cranial anatomy. Inside this, there is a parietal lobe, and midline there is a falx cerebri, which will be helpful in checking the patient's rotation. These two are the cerebral hemispheres. This falx cerebri is an important landmark during the CBCT matching also. So we will go slice by slice inferiorly to review the anatomy. This is a superior ventricular level where the lateral ventricles are filled with the cerebral. These are the lateral ventricles filled with the cerebrospinal fluid. That's why they are appear darker than the surrounding brain tissues. This ventricular system is used to assess the intracranial symmetry during the image guidance. Tumors or post-operative changes may cause the ventricular shape may be changed due to the operation, or it will shift from midline also. So understanding the normal anatomy is very important so that we can check the abnormalities in cancer cases, or if there is a post-operative cases. So I have given the numbers at the each anatomical part so that it will be clearly visible. The 55 number is given to the occipital lobe. This is at the posterior side of the brain. So moving inferiorly, this CT slide demonstrates the frontal lobe behind the frontal bone. This is the frontal bone, and the corpus callosum. This corpus callosum is seen at a centrally with connecting two cerebral hemispheres. The lateral ventricles are still visible, which will be helpful during the CVCT matching. So moving inferiorly, the ventricles are divided into other anatomical portions like frontal horn and occipital horns at this level. Other lobes are also available. The second one is a parietal lobe. This is a parietal bone. Another either side also, this is a parietal bone and this is a parietal lobe. At the back side, we have able to see the occipital lobe. While moving ahead, we are approaching the posterior cranial fossa, the pineal gland, which is located just below the third ventricle. This is 23 number is the third ventricle, contoured by the yellow color. These two are the horns, frontal horns. So 20 number is the cerebellum, and this is a pineal gland. In adults, it is sometimes visible as a calcified, appear dense on the CT scan. Posteriorly, there is a cerebellum. Here we can see this part is called cerebellum. So moving inferiorly, we are able to see the midbrain and cerebellum. This 20 number blue color is region is the cerebellum. 25th is the midbrain. This section demonstrates the transition between the cerebrum and brainstem. Here, the midbrain is a superior part of the brainstem and connects the cerebrum with the pons. Posteriorly lies the cerebellum, which coordinates this part coordinates the balance, posture, and motor control. Brainstem structures are among the most critical organs in the cranial radiotherapy. Even small overdose can lead to severe neurological complications. So during stereostatic radiotherapy, we have to match the brainstem and cerebellum to ensure the safe delivery of a dose. At this level, cerebellum occupies the larger portion of the posterior cranial fossa. The temporal lobes are seen here, denoted by the 19 number. On either side, these two lobes are seen. It is important structure during the posterior fossa tumors and predatory malignancies also. Now we have reached to the skull base, one of the most critically important level in a cranial radiotherapy. Pituitary gland, here we can see 33 number. All other structures are also able to say this. This is a frontal bone. 20 number is a temporal bone. This 42 number is a petrous ridge, which is important landmark at this level during the CBCT matching. Pituitary gland is at the midline. This is a sella turcica. It is responsible pituitary gland is responsible for regulating multiple endocrine functions. Posterior to the pituitary gland, this is a pons, which forms the middle portion of the brainstem. Laterally, the petrous ridge, temporal bones. These are the important temporal bone, and the petrous ridge is important landmark. So moving ahead, cerebral hemisphere and vermis. These two are the important structures at the posterior cranial fossa. The vermis occupies the mid portion. This 41 number is a vermis, mid portion of the cerebellum and connects both the hemispheres. The frontal sinus, we can see here, 43 number frontal sinus between the frontal bone. It looks black because of the air filled. It is also a very important landmark to match during the CVCT. And petrous ridge also, we can see the inner ear area here, denoted by 44 number. At the back side, we have 27 number occipital bone. Next, the sphenoid bone and the sphenoid sinus. Here, 48 number is a sphenoid bone, which is air-filled cavity just inferior to the pituitary gland. It is also a very important landmark in skull-based radiotherapy, and after the surgical procedure also. We can appreciate the the organs which are very close to the like optic chiasm, optic nerves are very near to this sphenoid sinus. So moving inferiorly, it is a superior orbital level. We can see the eye lens. Here is the lens. Optic nerve. Here it is optic chiasm. This is a lateral rectus muscles. These are the lacrimal glands. This is also lateral rectus muscles which holds the eyeball or control the eyeball movement. You can see the nasal bone, ethmoid sinus, and sphenoid bone is here. This is the temporal bone. So from here onwards, the organs are very closely attached to each other. So this is the last part of the orbit. In the last slice. Here 13 number is the inferior rectus muscles which holds our eyeball. 7 number is a sphenoid sinus which we can clearly see here for the matching purpose. 15 number is the nasal septum. This is very important landmark to observe the rotation during the CBCT images. 14 number is the nasal concha, which is a maximum which is occupied by the our nasal cavity. It divides the nasal septum divides it, our nasal cavity into right and left halls. These are important in sinonasal and orbital malignancies. These structures are. Then at the maxillary sinus level, we can see the maxilla and maxillary sinus, maxilla. This is maxilla. This is a 19 number is a masseter muscle. Parotid gland. Will start from here. Other structures are also there, like internal carotid artery, which is visible in the contrast scans. And 22 number is a master air cell, which will be helpful during the CBCT matching and to check the rotation because they are available at the both the sides. So here parotid gland is clearly seen at the nasopharynx level. 24 number is the nasopharynx. 20 number is a mandible. This is a mandible bone. We'll start from here. 17 number is a maxilla. 16 is a maxillary sinuses. 14 is a nasal concha. Parotid gland at the both side we can able to see. So nasopharynx lies posterior to the nasal cavity, superior to the hard palate. In next slide we will see the hard palate. This region is important in the nasopharyngeal cancer, and mandible is very important landmark in this slide. So moving inferior, hard palate is visible here. It forms a bony roof over the oral cavity. So separate nasal cavity from the oral cavity. So understanding its position is important when treating oral cavity and sinonasal tumors. Parotid gland we can see here. Radiation oncologists always controls this parotid gland to reduce the dose to the parotid gland so that we can able to see with, during the CBCT match. So moving inferiorly, here we can clearly see the parotid gland at the both sides. It will be a very it will be helpful to check that the weight loss of the patient after the 10 to 15 fraction, so that if the parotid glands are reduced in size or the weight loss is there, so that particular patient or if there is a seroma at the near the oral cavity or buccal mucosa level, so that that patient we can select for the adaptive radiotherapy. So it is a very important landmarks, this parotid glands, because they are producing saliva. So those to the parotid glands should be restricted so that xerostomia, like dry mouth condition, will not be happen. That we have to take care. So moving inferiorly, we can see the tongue, the 28 number. Parotid glands C1, this is C1 without the spinous process, and this is C2, and this is the nasopharynx. This C2 helps in rotation of the head. So this is also C1 and C2 also very important landmark while taking the lateral image of the patient in 2D or as well as in 3D images. So at the oral cavity and upper oropharynx level, you can see the tongue. This is the uvula. We can see at the end of the soft palate, carotid glands are clearly visible. Here we can see it is not contour, so that we can see the borders. 20 number, this is a mandible, and tongue occupies maximum area of the oral cavity. So maximum tumors are oral cavity tumors are lies between this area. So this is very important slide. So tonsillar region also, these are the tonsillar regions. This is a tongue, a symmetrical tongue. In post-operated cases, we will not able to see this whole the tongue area. Only the half of the tongue is it will be available for the matching. So this is the oropharynx area. 24 number is a nasopharynx, and this is the start of the oropharynx. Below this, the oropharynx will start. 26 number is the jugular vein. Here is a 36 number are the palatine tonsils. Here one side is contour, another side is kept as it is. You clearly see parotid glands are still visible here. So this is a posterior phalangeal wall. This is the last end of the soft palate. This is the base of the tongue. 39 number, we can see the submandibular salivary glands, which has also helps in salivation. So they are very close to the oral cavity. So matching them, it will be a very difficult task during the treatment if the post-operated cases are there. So this is the C3 vertebrae. We'll start from here. So this submandibular glands contribute significantly for the saliva production. So those matching this perfectly is very important. So 20 number is mandible. This is the lower jaw, mandible. So hypopharynx. Hypopharynx is this is the 42 number. 43 number is the epiglottis. We'll start from here. Still, we are able to see the submandibular salivary glands. This C4 vertebra will start from here. The cases are like pyriform sinuses, posterior pharyngeal wall, and post-cricoid region. Cases will be here. So hyoid bone. This is a U-shaped hyoid bone suspended by the muscles with other bones. It serves as an attachment point for the tongue and laryngeal muscles. The hyoid bone is an excellent landmark for identifying the transition between the oropharynx and the hypopharynx. Movement of hyoid bones occur during the swallowing. So we should consider that also. Here we can see the C4 vertebra, mandible also here. So moving inferiorly at hyoid bone level, this is the epiglottis. Below that, there is a hypopharynx. The submandibular ends here at the C4 level. We are now approaching the upper larynx. So larynx will start from here. The thyroid cartilage is denoted by this green color. It is the largest cartilage of the larynx, laryngeal skeletal. Posterior to the airways, there is a esophagus. You can see the esophagus will start from here. Epiglottis is at the upper epiglottis. The function of epiglottis to close the trachea at the time of swallowing. So esophagus distinction from the surrounding tissue can be sometimes be challenging on the non-contrast CT. So at the C5 level, so this is a laryngeal inlet. This demonstrates the larynx. 50 number. 43 is the epiglottis, and 47 is the esophagus, which is very difficult to see here. Laterally are common carotid artery. In the contrast scan, we can see the larynx should be carefully identified because the unnecessary radiation can affect the voice quality and swallowing. Here we can see the uh, black air. We are continuing further the lower larynx and the surrounding cervical anatomy and the thyroid cartilage of the larynx, esophagus, C6 level, the carotid artery. Then cricoid cartilage of the larynx. It is at the lower larynx. It is a complete ridge of cartilage in the airway. Cricoid cartilage, 55 number. Then below there is a esophagus. 48 is a cricoid cartilage of larynx. Here we can see this is a complete ring, which is not controlled. The half part is contour, half part is remaining. So inferiorly, the airway continues as the trachea, which will become visible in the next few slides. Esophagus lies posterior to the trachea. So thyroid gland will start from here. These are shown by the green color, 56 number. The understanding the lower neck anatomy is very essential because treating the thyroid malignancies or supraclavicular nodal region. Trachea is an excellent internal anatomical landmark during the CVCT because of the air field. So C7 vertebra serves as an important bony landmark during the image matching. We can able to see the rotation of the patient. So trachea still maintains the air field appearance. This is thyroid gland. This is the esophagus. You can see. So these three are provide a important landmark during the image verification. This is the lower neck part of the head and neck anatomy. So he will start with the thoracic inlet, the clavicle, scapula. Scapula is here. This is scapula, and this is spine of the scapula. Head of the humerus will start from here. Ribs, esophagus, and trachea still visible. So this is the upper thoracic level. The spinal cord will start visible from here. This is a lung, apex of the lung. Ribs. First one is a clavicle. We are able to see the scapula, scapula spine. Moving inferiorly. This CT slide demonstrates the sternum, trachea, esophagus, and thoracic vertebrae. This is the lung of all the black area, black air cavity. So we should confirm with the surface anatomy with the internal anatomy at this area during the breast treatment or mediastinal treatment. This is scapula. So here the thickness of the esophagus will be very less. The esophagus shown by the 11 number. This is the trachea, spinal cord, sternum. So moving inferiorly. This is a tracheal bifurcation, that is carina. It divides trachea into the right and left bronchus. So carina is one of the most reliable internal anatomical landmark commonly used during the thoracic treatment. So during the CBCT matching in a lung cases or mediastinal tumors also, it is reproducible. So this is that part of the carina, so that the breast tissue will start appearing here. These two are the bronchus. This is a left bronchus and a right bronchus, because in the previous size carina is bifurcated to left and right bronchus. This 11 number shows the esophagus opening. Breast tissues are clearly seen. The other side is not contoured to show the breast tissues. Esophagus lies posteriorly. At this slide, esophagus is also very important landmark if it is not a CA esophagus patient. So at the lower thoracic level, this is a transfer process of the spine, and this is a spinous process of the spine. In sagittal image, we can match with the transverse process, and in lateral image, or we can match with the spinous process in a lateral view. In axial image, we will match with the transverse process. So descending aorta is visible here. This is a descending aorta. Xiphoid process, this 10 number denotes. Second number is scapula. So thoraco-abdominal junction. Sixth is the rib. This is a descending aorta. Esophagus is still available. At this level, the thoraco-abdominal junction, the movement is much because of the diaphragm and lung and liver. So abdominal compression plate is required, or 4D simulation is required for the treatment of this abdominal or thoracic junctions. That will be helpful so that the movement of the structures will be restricted. So now we are starting the abdominal section. So the upper abdomen, this is a part of the liver. Esophagus is seen here. Sixth number is a inferior vena cava. This is the starting of the stomach. Third number. Fourth is a descending abdominal aorta. Fifth is a thoracic vertebra. Still we are at the thoracic vertebra level. So at abdominal, at this level of treatment of the tumors, the empty stomach protocol or DABH protocol or abdominal compression plate, these are the useful devices to restrict the motion. So at this level, we can clearly see the spleen and the liver. Below that, there is the inferior vena cava. Second one is the esophagus. This is the esophagus and stomach junction. Uh, so from now onwards, we will not able to see the esophagus. This is the last slide. This is the stomach. This slide demonstrates the transition into the lumbar vertebra. Lumbar vertebra will start here. Here the spleen is visible. Stomach, we are not able to see the esophagus. This is the liver. So the lumbar vertebral bodies provided an excellent landmark for image matching and the surrounding tissues. The knowledge of this anatomical information is very important. Our stomach is yeah, after the taking the food, our stomach is moving in laterally, anteriorly, and inferiorly also. So the stomach shape of the stomach will vary from patient to patient. So here we can see the hard portion is lying down posteriorly, semi-solid, and air is at the upper level because of the heavy food will be at the lower section. Here we can see the pancreas. This red portion is a pancreas, which is surrounded by this duodenum. Sixth is a gallbladder. This is the liver. Fifth will the kidney will start. Fourth is a spleen. This is stomach. So for the pancreatic treatment, stereostatic body radiotherapy procedure should be implemented because it is very close to the other critical organs, and its position will be changed due to the presence of the stomach or breathing motion also, or if stomach is full, so we have to implement the empty stomach protocol in these cases. At this level, kidneys are clearly seen. The one kidney is contour, another one we can see here. This is the pancreas by red color. Stomach. This is the gallbladder. Fifth, this is liver. So kidney will clearly see the kidney as a landmark at the time of CBCT matching in the abdominal region. Till we are at the lumbar vertebral region. So moving inferiorly, this is a psoas muscles close to the kidneys. will start from here, liver, and small bowels, which is shown by the yellow. This is the stomach. This is almost end of the stomach. Small bowels are just there is a difference between a small bowel and a large bowel. We can see that there is no air cavity inside the small bowel. You will able to see the air inside the large bowel in the next slide also. These are the kidneys. This is this is left kidney. This is the right kidney. You can clearly see in the CBCT images or the CT images. So the blower filling protocol is must in abdominal region, especially. So moving inferiorly, this green is a small bowel. This is a psoas muscle close to the kidneys. Third number is a ureter, which transports the urinary secretion from the kidney to the bladder. Here is a liver. Spleen is not, we will not able to see the spleen at this level. So psoas muscle is a very important landmark for the CBCT matching and stable structure. So other major vessels like fifth is the inferior vena cava and fourth is the descending abdominal aorta. Clearly we can see here. 8 number is the descending colon, ascending colon, and 9 number is the descending colon. So food will enter from the stomach, then will it enter in the duodenum, then inside the small bowel, and from small bowel to the ascending colon, then at the upper level to the transfer colon, and from transfer colon it will transport it to the descending colon, then sigmoid colon and rectum. The abdominal aorta we can able to see, and psoas muscle, the rigid structure is here. You can see the small bowels shown by the green color. Yellow color is the ascending colon. This is the sixth number is the common iliac arteries. This is the lumbar vertebrae. Still we are at the lumbar level, and the shape and structure will be changed depending on the stomach and the fasting protocol of the patient. So at this level where the ilium is visible, the psoas muscle clearly sees. This is the cachium, the starting of the ascending colon, where the from small bowel to the ascending colon there is a cachium. Sacrum, we are at the pelvic level. The sacrum will start from here. So moving inferiorly, psoas muscle are still here supporting the pelvis. Appendix, this is not always clearly able to see. It is not contour also, but it helps in identifying the pelvic anatomy. These are the small bowels. Fifth number is the descending colon. So ileum will start from this slide. Sigmoid colon. Fifth is the sigmoid colon. From here onwards, the rectum will start. From sigmoid colon to the food will the fourth number is a small bowel. So we can see the maximum area in the abdopelvic region is occupied by the small bowel and the large bowel. Third one is the sacrum. So this slice is important to check the rotation at the pelvic level. So moving inferiorly, this is the piriform muscles, which are also useful as a soft tissue landmark during the pelvis imaging. Fourth level is the small bowel. Fifth is the sigmoid colon, which connects at the rectum here. In next slice, we are able to see. Sorry. They are commonly used in junction with the bony landmark, the psoas muscles, piriform muscles, and the uh, sacrum and ilium. So from here onward, this is a male pelvis we are verifying. The sixth is a bladder will start from here. This is a rectum controlled by the yellow. Second number is ileum. Third is a sacrum. So moving inferiorly. So bladder, position of the bladder or bladder filling will affect the position of the rectum also. And rectal gas will affect the seminal vesicles and the prostate also. This is the rectum. These are the seminal vesicles are commonly included in the treatment volume for the prostate cancer. Seminal fluid is produced and stored in the seminal vesicles. Their position may be vary because of the filling of the bladder. So this posterior bladder wall is act as an important landmark for the matching of the prostate tumors. So here we can see the femoral heads. So prostate will start from next slide. Here still the seminal vesicles are visible. These are feathery structures. Third one is a pubic will start from at this slice. Femoral head. We are always considering these are the important landmarks for the rotational verification in the CBCT images. This slice demonstrates the prostate gland. It is a walnut-shaped structures between the rectum and the bladder. Bladder is at the anterior, posteriorly rectum. Is commonly treated in male pelvis, and it is a movable area, particularly due to the gas filling in the rectum also and bladder filling also. So in prostate radiotherapy, bladder protocol should be followed perfectly with the empty rectum. Instruction should be given to the patient because it is affecting our the dose delivery to the prostate. So prostate will shift day to day. So moving inferiorly, the male pelvis section. These are the pubis bone, the rectum, and the prostate. The small part of bladder. Femur will start from here. So now we are at the last slide of the male pelvis. Anus at this level, penis. Second with the ischium. Ischium bone is also it is not normally contour unless in rectum cases or we are going to treat the penis area. The inguinal nodes are contoured here, both sides. Otherwise, this part will be not contoured. So we will start with the female pelvis. We will start from the pelvis only. There are not much difference. Only the important structures we will discuss. The female anatomy is essential for the cervical, endometrial, vaginal, or ovarian cancer treatments. These slides demonstrate the uterus, the ileum. This is a rectum. This is a sacrum. So moving inferiorly. So bladder filling is important in this pelvis cases. Here we are able clearly sees the ovaries. Fifth number, green color. Third one is the rectum. Ovaries are attached with the fallopian tubes with the to the uterus. So in some cases, ovaries are shielded to avoid the dose. So moving inferiorly, here we can see the ovary is clearly visible here. Third one is a rectum. Second is a coccyx, femoral heads, which is very important landmark to check the rotational. Ovaries are very radiosensitive organs here. This is the uterus. It's not contoured. This is the bladder. Moving inferiorly. This is the femoral head, bladder, and the cervix we can see here, fourth number. It is sandwiched between the vagina and the uterus. This is rectum. The city appearance of the this uterine body can be vary. Uterus sometimes maybe fall on the bladder, sometime the changes will be occur according to the age. Also, the post-operative changes is also observed. The opening of the uterus is called as a cervix. So here at the fourth, vagina. Third is the rectum, which shows the gas. Bladder is filled. This is the femur. We'll start from here. So in a gynecological treatment, we have to match this at this level to check the rotation, bladder filling, or yeah, the rectum filling or rectum empty, the position of the rectum. The bladder filling completely change the position of the uterus and cervix and vagina also. And so moving inferiorly, here we can see the pubis. Fourth one is a bladder. Then below that is a urethra. Sixth is vagina. Seventh is the anus. And this is the femur. So radiation therapy should utilize both bony and soft tissue anatomy during the CBCT matching. The soft tissue structure may change, like bladder may change, gas, presence of gas or feces will change the position of the rectum also, or rectum will be filled. So this is a lower female pelvis area. Femur we can see here, the ischium, and the vagina includes the urethra. So daily imaging is required at the pelvis level to match the important structures. So our responsibility is it is beyond matching, beyond the operating the machine. We play a role of clinical judgment. We observe the clinical anatomy. We observe the treatment related changes in patient body. We inform them to the doctors. We maintain the patient safety also. We are documenting that changes and communicating with the multidisciplinary team. So these are our responsibilities. So together, these responsibilities contribute to the safe, accurate, and high quality radiotherapy treatments. Thank you. Thank you so much for your kind attention.